Welcome to the Explainer. All right, let's talk about something you probably see every single day at the pharmacy counter, premenstrual syndrome, or PMS. We're going to break down the clinical essentials so you're totally prepped for that next patient consultation with some solid, evidence-based advice.
So, here's how we're going to tackle this. We're going to walk through it just like a real clinical encounter. First, we'll nail down what PMS actually is. Then we'll get into how to confirm it's really what's going on. After that, the patient consultation itself, what that looks like. From there, we'll dive into all the evidence-based treatment options you have in your toolkit, and finally, we'll wrap up with how to monitor therapy and handle follow-up. Sound good? Let's jump in.
Okay, first things first. Let's build a really solid clinical foundation here. When a patient comes up to you and says they have PMS, what are we actually talking about, clinically speaking?
And we have to start with just how common this is, because the numbers are, well, they're staggering. We're talking up to 90% of people who menstruate will experience PMS symptoms at some point. Think about that. That massive number means this is hands down one of the most common things patients are going to ask you about over the counter.
Okay, so if there's one thing to take away from the clinical definition, it's this. Timing is everything. PMS isn't something that's there all the time. It's all about that cycle, right? The symptoms pop up after ovulation. That's the luteal phase. And, just as important, they vanish once menstruation starts. That distinct on and off pattern, that's the key. It's the diagnostic linchpin.
And that timing piece brings us to a really critical distinction you need to make. PMS versus its much more severe cousin, PMDD. Now, the difference here isn't really about the types of symptoms. It's all about their impact. PMD gets diagnosed when those symptoms are so bad they cause clinically significant distress. We're talking it's actually getting in the way of someone's work, their school, or their relationships.
And wow, look at the difference in how many people this affects. It's huge. While almost everybody deals with PMS at some point, true PMDD is way less common, only about 3 to 8% of people. And for you in the pharmacy, recognizing this gap is so important. It helps you know when a simple OTC recommendation might be enough versus when it's time to say, hey, you should probably see a doctor about this.
Okay, so if that cyclical pattern is the absolute key, then how do we, confirm it? Well, it's not always as simple as you think. In fact, trying to diagnose PMS can be a real clinical challenge.
And get this, it's so tricky that some clinicians even question if PMS is a real thing. Now, why would they do that? Well, because there's no blood test, no biomarker you can check. It's what we call a diagnosis of exclusion. And that is exactly why your systematic approach at the counter is so crucial. You're helping to rule out everything else it could be.
So this basically gives us a mental checklist to run through during any patient consultation. You've got to ask these questions. Are the symptoms only showing up in that luteal phase? Is there a clear, symptom-free week right after their period? And are these symptoms actually interfering with their daily life? Running through this helps you filter out other possibilities, like underlying depression or even a thyroid problem.
So what's the gold standard? The only way to really truly confirm that cyclical pattern is to have the patient track their symptoms, day by day. We're talking about perspective monitoring, basically keeping a daily chart for at least 2 full menstrual cycles. That's what takes this from just being a hunch to a real, data-driven conclusion.
And this is exactly where you, as the pharmacist, play such an important role. You're in the perfect spot to actually guide patients through this whole assessment process.
So you can be super proactive here. Recommend a simple tool, just like this daily symptom diary. It does 2 amazing things. First, it gives you the objective data you both need for a real assessment. And second, it really empowers the patient. It gives them a sense of control and a better understanding of what's happening in their own body.
And while you're guiding them through this, part of your job is also triage. Let's say that symptom diary starts showing really severe, debilitating symptoms, especially if there's a big psychological piece like extreme irritability or a really low mood. That's a huge red flag. That's your cue. That's the point where you need to say, okay, it's time for referral for a full PMD assessment.
All right, so now we get to the fun part, the core of what we do as pharmacists, pulling out our toolkit. Once you've reasonably established that it's PMS, what are the evidence-based treatment options we can actually recommend?
So the evidence really points to what's called a step care approach. You start with the least invasive stuff that can have a big impact. We're talking lifestyle and diet changes. From there, you can move up the ladder to vitamins, then OTCs. And finally, you'd consider prescription therapies for symptoms that are more severe or just won't go away.
So when it comes to non-drug counseling, you've got some heavy hitters. The evidence for regular, moderate aerobic exercise is really strong.
It's been shown to help with a whole bunch of symptoms, and simple dietary tweaks like cutting back on caffeine and salt are also totally reasonable recommendations that can make a real difference for things like breast tenderness and bloating.
Okay, now for when a patient walks up to your counter looking for a product. We have some really good evidence for a few options. First up, calcium carbonate. At 1,200 milligrams a day, it's been shown to help with mood, water retention, and pain. Then you've got vitamin B6, which is also effective. But, and this is a huge counseling point, you have to tell patients not to go over 100 milligrams a day. Any higher and you risk peripheral neuropathy. And of course, for any pain-related symptoms like headaches or muscle aches, NSAIDs are your go-to.
Okay, let's talk about prescription therapies, where you'll be working alongside a prescriber. SSRIs have the best evidence, hands down, especially for the psychological symptoms you see in severe PMS and PMDD. And what's really interesting is that they can be dosed all the time or, get this, just during the luteal phase. Combined oral contraceptives are another reasonable option, especially if the patient also needs contraception, though I'll say the evidence for them with PMS is a bit more mixed.
All right, last but not least, let's talk about closing the loop, because your role as a pharmacist doesn't just stop once you make a recommendation. To really manage PMS effectively, you need that ongoing monitoring and follow-up.
So the key here is to tell the patient to keep using that symptom diary. It's not for diagnosis anymore. Now it's their tool for tracking whether or not the treatment is actually working. Tell them, hey, if things aren't getting better in about 1 to 3 months, check back in with me. And that follow-up conversation, that's also your perfect opportunity to screen for any side effects from whatever therapy they're on.
And all of this leaves us with a final thought, something to really think about in our day-to-day practice. The source material points out that there are over 100 different symptoms that have been linked to PMS. So while we have some fantastic evidence-based tools in our toolkit, the sheer variety of this condition is a constant challenge. It's a great reminder that for PMS, personalized care and just staying engaged with your patient, that's really the key to navigating this whole complex spectrum.